So if you're undergoing an interventional radiology procedure and you are taking blood thinners or anticoagulation, one of the key things to consider is how to manage the anticoagulation before, during, and after the procedure. Whether you're taking anticoagulation for a heart condition or a deep venous thrombosis or DVT, adjusting the dose and timing of the anticoagulation is key for the safety and success of your procedure. So let's break it down. First, let's talk about what are the types of anticoagulation. So the usual blood thinners, the most common ones nowadays, are called DOAC. DOACs is a term for direct oral anticoagulants, and they include oral medications like Eliquis and Xarelto, which are the most common ones, but also include injectable subcutaneous medications like Lovenox. Lovenox can also be called low molecular weight heparin. There are also other types of anticoagulation that are not as common these days. One is warfarin that we use for like many decades. And it's a great drug, but it's not used anymore as often because it's difficult to manage and requires an intermittent blood test to make sure it's working. If you're admitted to the hospital, sometimes you're also using IV drip blood thinner called heparin that can be adjusted very quickly, and we're going to talk a little bit about it. But there are also other more rare anticoagulations that are only used in certain conditions, such as Pradaxa, Argatroban, or Arixtra, that are beyond the scope of this video, and if you are in any one of those, you should ask directly your doctor. Another category of quote-unquote blood thinners is the antiplatelet agents. These are like Aspirin, NSAIDs, or Plavix. And each one of these has a little bit different half-lives, therefore the adjustment can be a little bit different. So managing the anticoagulation before and after your IR procedure will depend basically on two factors. One is the risk of bleeding of the procedure. Obviously, some procedures have a higher risk of bleeding, whether other procedures have almost no risk of bleeding, so we don't even need to stop the blood thinners. But also we need to take in consideration the risk of stopping the anticoagulation. What's your risk of developing a clot if we stop the anticoagulation for a few days? Some patients may not have a lot of risk, and you can stop even for a week to 10 days and they will be fine. And other patients, for example, patients that have mechanical heart valves, the risk of stopping may be so high they may be worth taking a slightly higher risk of bleeding with the procedure than actually stopping the blood thinners. Now I'm gonna talk about the general recommendations from our practice that we generally use. But every case is a little different. So if you have questions or some concerns, it's always better to talk directly to your physician or your interventional radiologist. In our case, just reach out to us and ask if you have any specific questions. If you are on DOACs like Eliquis or Xarelto, then we usually stop the anticoagulation 2 days before the procedure and we restart the day after the procedure. But if your risk of clotting is high, sometimes we may stop just a day before the procedure and restart almost immediately. Now, the one exception to the rule is patients that have chronic renal insufficiency or patients that are on dialysis and are taking anticoagulation. So if you are on DOACs and you have chronic renal insufficiency or renal failure, you may stay for a longer period of time. So in those cases, you may need to stop even more than 2 days before your procedure. So we need to be very careful with that. Coumadin, stop 5 days before your procedure and can resume the day after the procedure. So the Coumadin, for example, if we stop 5 days before the procedure, it'll probably be working for another 2-3 days. But if we start the day after the procedure, the Coumadin could take up to a week to be working again. So if your risk of clotting is high, then we do what's called bridging. And you need to contact us or contact the anticoagulation clinic or your cardiologist who is managing your anticoagulation. Now, if you're at very high risk of clotting, we may start you on a medication called Lovenox while you're off Coumadin. And the advantage of the Lovenox, it has a short half-life and can be stopped just 24 hours before the procedure. The Lovenox also works right away after we start it again, whether the Coumadin may take a few days to work. Heparin, which is the IV medication I told you that patients sometimes receive during a hospital stay, that can be stopped only 3-4 hours before the procedure and will be all gone. That's the main advantage of the heparin. You can stop right away, and you can also restart whenever you want, and it will be working almost immediately. In some patients with really high risk of clotting, we actually admit the patients to the hospital, we start them on heparin, and then we stop just before the procedure, and then we can restart after the procedure, if it's a high-risk procedure, of course. The antiplatelet agents. For interventional radiology procedures, most of the time they don't need to be stopped, although for biopsies in general, especially like a kidney biopsy or a liver biopsy or a lung biopsy, which have a slightly higher risk of bleeding, we tend to stop them. And when you stop antiplatelets in general, you have to stop them for 7 days before the procedure. So not all procedures require you to stop. For example, vascular procedures where you get access directly in an artery or a vein, sometimes we actually don't want you to stop the anticoagulations. We certainly don't want you to stop the antiplatelet agents. We use closure devices for this procedure, which is a little stitch that goes into the blood vessel to prevent bleeding, and so stopping the blood thinners is not really necessary. Indeed, for most arterial procedures, we actually use a blood thinner during the procedure to prevent clot from forming in the catheters. Low-risk biopsies, for example, a lymph node biopsy or a bone marrow biopsy, we don't need to stop the blood thinner since the risk of bleeding is so low that it's not necessary. Other biopsies, such as a liver biopsy or a kidney biopsy or a lung biopsy, we definitely want to stop those blood thinners. Thoracentesis and paracentesis, when we remove fluid from around the lungs or in the abdomen, they're usually low risk. But in general, since patients may require repeated treatments, we recommend stopping the blood thinners if the patients are low risk of clotting. But if the patient has high risk of clotting, we definitely don't need to stop the anticoagulation for that. Antiplatelets are usually okay for those procedures. Other common procedures like Mediports or tunnel lines or even Plavix catheter placements, we prefer to stop the anticoagulation for 2 days or so. But again, if the patient is high risk for clotting, we do not need to stop, and we're comfortable doing those with the anticoagulation as well. And of course, these are just general recommendations, and it is useful, but every case is different, and you really should discuss this with your interventional radiologist or the physician who prescribed you the anticoagulation to have a risks and benefits discussion. Who are considered patients that are high risk for clotting when stopping the anticoagulations? So certainly patients that have mechanical heart valves, or patients that have atrial fibrillation with a history of stroke, or patients that have a recent pulmonary embolism, especially if the pulmonary embolism was a severe one. Now, patients who have history of DVT and have been on anticoagulation for years, or patients who have a history of remote pulmonary emboli that happened several months or more ago, those are usually not very high risk, and those usually can stop the anticoagulation even for a week to 10 days without any problems. Also, patients that have been diagnosed with atrial fibrillation but never had a history of stroke, those are usually considered low risk for stopping the anticoagulation for a few days. If you're on blood thinners, here's a quick checklist and summary for you to follow if you're having an interventional radiology procedure. First, inform your interventional radiology team about any blood thinners you may be taking, and talk to your primary care physician or the physician who prescribed these blood thinners. Have a discussion whether the procedure you're doing is a high risk of bleeding procedure, and what is your risk for stopping the blood thinners. Third, if you're on Coumadin, ask if you need any bridging therapy. Again, the bridging therapy is when you start Lovenox after stopping the Coumadin. And fourth, when you have a procedure, make sure you have a plan on when to start again the anticoagulation. And this is a quick recap of the most common medications. Eliquis and Xarelto, you should stop for 2 days before your procedure and can resume the day after the procedure. Coumadin, stop 5 days before your procedure and can resume the day after the procedure, but ask your doctor if you need bridging. Lovenox, you can stop 24 hours before your procedure and resume the day after the procedure. And Heparin can be stopped a few hours before the procedure, and it's fine. And remember, if you have chronic venous insufficiency or you're on dialysis and you are on DOACs, You may need to stop more than 2 days ahead of your procedure because they stay longer in the system. By following these steps, we can certainly minimize the risk with your procedure and make sure things run smoothly. Thank you so much for watching, and if you have any questions, send us a My Health Online message and we'll be happy to clarify things.